Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, everyone. Welcome to the University of Michigan Radiology Vault. I am Ashish Wasnik, an abdominal radiologist at Michigan Medicine, and today I'll be talking about imaging in bariatric surgery, postoperative anatomy. I have no relevant disclosures for this presentation. Primary goal of this talk is to review bariatric surgical procedures and normal postoperative anatomy on imaging. Bariatric surgery can be divided into three types: restrictive, where the goal is to create a small volume stomach, and these includes sleeve gastrectomy, laparoscopic gastric band, and vertical band gastroplasty. Malabsorptive, where the primary goal is to bypass a segment of the small bowel to reduce nutrient absorption, and this includes jejunal-ileal bypass. And then a combination of malabsorptive and restrictive procedure, which is the Roux-en-Y gastric bypass. So let's talk about imaging in bariatric surgery. Imaging is performed primarily in the early postoperative period to evaluate for complications based on clinical presentation of the patients, primarily to look in for leaks. In the long term, imaging is performed to assess for any stricture or obstruction, and also in cases where the procedure is performed at an outside institution to understand the operative anatomy. When talking about the upper GI imaging, upper GI fluoroscopic examination is the imaging modality of choice, as this is a more dynamic procedure that you can actually follow the water-soluble iodinated contrast. An important point to remember is that a scout and delayed views are extremely important because these can help you to define if an extraluminal contrast is truly a contrast or is an artifact that has been present on the scout. The delayed views help you to understand that if the leak persists, and secondly, over the course of the time, there is increased intraluminal pressure, which can help to better delineate any subtle or contained leaks. Additional point to remember is to always track the contrast column and to obtain different views and projections to identify the surgical anatomy and also to evaluate for any leak or complications. CT imaging with oral contrast using water-soluble iodinated contrast and intravenous contrast are also useful to evaluate for the collections, the size, as well as to assess other complications, including bowel obstruction or internal hernia. So let's go deeper into the different surgical bariatric procedures. Sleeve gastrectomy. Sleeve gastrectomy is a restrictive bariatric procedure in which a portion of the stomach is removed. It has shown to achieve superior weight loss compared to some of the procedures that are commonly done, such as Roux-en-Y gastric bypass. However, remember, this is an irreversible procedure. So here is an illustration demonstrating a sleeve gastrectomy. As you can see that there is an elongated staple line that extends from the level of the gastric fundus all the way to the greater curvature in a primary goal to create a small volume gastric sleeve, as you can see in this image right here. The goal is to have the gastric volume of approximately 100 to 150 ml. And then the excluded portion of the stomach outside of the staple line is then surgically removed. On the radiograph of the abdomen on a frontal view, you will see a staple line that typically follows from the gastric cardia along the greater curvature of the stomach. And on the CT scan, you can very well see a hyperdense surgical staple line that is seen now along the outer or lateral margin of the stomach. On a fluoroscopic imaging, what you see is a small linear channel that is from the small volume stomach that is extending all the way down. In some instances, you will see a capacious segment of the gastric pylorus antrum based on how the surgical staple line was put. Typically, these are more perpendicular. Additionally, to note is given the loss of esophagogastric angle in these patients with sleeve gastrectomy, this poses an increased risk of hiatal hernia and reflux. Next up, let's talk about laparoscopic adjustable gastric banding. This is also a restrictive bariatric procedure, and this was introduced in 1985 and approved in the United States in 2001. This is reversible and is the least invasive of the weight loss surgeries that we have. However, it does require some modification in the eating habits, and the studies have shown that it causes slower initial weight loss and might need regular follow-ups. Now, looking at the technique and anatomy, the primary goal is to have a small gastric volume, which is achieved by laparoscopic placing a silicone band, which is radio-opaque, with an internal inflatable balloon placed around the proximal stomach, that is approximately 2 to 4 centimeters from the gastroesophageal junction. This is then connected to the goal is here to create a small gastric pouch, approximately 3 to 5 centimeter, with an adjustable stoma, which is around up to 4 millimeter wide. The balloon can be inflated or deflated by injecting or aspirating saline from a subcutaneous port, and then which is attached via tubing to the band. So on imaging, if you look at the lap gastric band, you will see the radio-opaque lap band, which is as seen here, and then you'll have a small portion of the gastric pouch above the band. This is a small stoma, which is expected to be around up to 4 millimeter wide, and then you'll see opacification of the remainder of the stomach. Also, when you're looking at the band to evaluate, carefully look at the tubing that connects to the subcutaneous port, because an acute kink or a discontinuity or broken tubing may result in malfunction of the gastric band. Another thing to remember about gastric band is the phi angle, which is an angle created by drawing a line parallel to the spinal column and a line parallel to the lap band. And this phi angle should be less than 58 degrees, or in a range of 4 to 58 degrees. And this is on an anteroposterior or a frontal view of a radiograph or a scalp. It is important to know that an increase or a decrease in the angle is suggestive of band malfunction as well as slippage of the lap band. On CT, when you're looking at the lap band, you see this high density band, and then within it, along the inner aspect, you can see a silicone band, which is actually fluid filled, and this is what is inflated or deflated with the saline that is injected through the subcutaneous port. Now let's talk about vertical band gastroplasty. This is another of the restrictive bariatric procedure that was introduced in the early 1980s. However, given frequent complications associated with this kind of surgical procedure, it has now gone out of vogue and is obsolete. The complications that we have seen with vertical band gastroplasty is suboptimal weight loss, persistent vomiting, and also gastroesophageal reflux. Here is an illustration of vertical band gastroplasty. Again, the primary goal is to create a small volume pouch, and that is done by creating a vertical stable line along the medial aspect of the proximal stomach is a small pouch, and then the excluded stomach is communicating down. However, the decrease in the volume and the decrease emptying is reinforced by creating a band which is at the exit window of the pouch. This is a barium fluoroscopic examination of this in this patient who had a past history of vertical band gastroplasty. You can see that this is an esophagus with a small hiatal hernia, but then there is a staple line that separates the stomach into two portions, a small portion which is the gastric pouch and a narrow stoma which is created by the band. And you can see that the contrast does communicate with the excluded portion of the stomach. However, the primary goal is to have a small gastric volume pouch with a band that causes early satiety in these patients. Now moving on to Roux-en-Y gastric bypass, that is one of the common surgical procedures done. This is both restrictive and malabsorptive because the goal is here to reduce the volume of the stomach but also to bypass a portion of the small bowel. This has shown to cause more permanent weight loss than any other methods. With the introduction of laparoscopic technique in 1994, studies have shown that Roux-en-Y gastric bypass with LAP has led to quicker recovery, decreased hospital stay, and decreased surgical complications. Now, talking about the technique itself. So the primary goal again is to create a small gastric pouch along the proximal stomach, approximately 15 to 20 ml. So the jejunum is then divided approximately 30 to 40% distal to the ligament of Treitz, and then this portion of the jejunum is brought up and anastomosed to the gastric pouch, creating a gastrojejunostomy. And this limb then becomes the efferent or the Roux limb. The gastrojejunal anastomosis can be end to side or side to side anastomosis. Eventually, the remnant stomach, which is, as you can see here, this is now becomes the biliary limb or the afferent limb, and this is anastomosed to the efferent limb approximately 100 to 150 centimeter distal to the gastrojejunal anastomosis, creating a jejunojejunal anastomosis, as you can see, and further down is the common channel. On fluoroscopic imaging on an upper GI examination, as you can see, this is the stomach, the esophagus, which is filled with contrast, a small gastric pouch, and then a feathery appearing jejunum, as you can see. Note that you do not see opacification of the excluded stomach or the biliary limb, because that would suggest that there is some communication. However, in some instances, you will see a reflux of contrast that goes towards the duodenum. Additionally, a surgical drain is present on this patient with a post-operative day 3. In this example, you see an esophagus, that is the site of the gastric pouch, and a gastrojejunal anastomosis going down with the jejunum. On these two different projections, what you notice is this focal outpouching at the gastrojejunal anastomosis, and this might be easily mistaken for a leak. However, if under fluoroscopic imaging, you will notice that this fills up with the contrast and then empties back, and this is actually a normal anatomic variant in a end-to-side anastomosis. So this is the blind ending stump of the jejunum before it's anastomosed to the stomach. On CT imaging, you can see that the excluded stomach is decompressed going along the duodenum, which is the now called as the biliary limb. And if you look at the pouch itself, from the esophagus, this is a small portion of the gastric pouch filled with contrast, and it goes down into the jejunal anastomosis. When you look at the Roux limb can be anticolic, that means anterior to the transverse colon, or it could be posterior, also called as retrocolic orientation or position of the Roux limb. Why is this important is because these are the potential spaces created within the mesentery that can serve as a nidus for internal hernias. And this is an illustration to show a Roux-en-Y gastric bypass with 3 potential space that has been created that can serve as a source for internal hernia. Just posterior to the Roux limb, as you can see, you will find a space which is called as the Peterson space. If an herniation occurs in a Peterson space, the jejunal anastomosis, which is always on the left side of the midline, will be seen towards the right side of the abdomen. Secondly, you can have a defect present at the jejunal anastomosis, and this is a mesenteric or transmesenteric internal hernia can occur, and this instances the JJ anastomosis is on the left side of the abdomen. And third, on the retrocolic type of anastomosis of the Roux limb, there could be a potential defect that can serve as a nidus for herniation behind the colon. Next, we'll talk about jejunoileal bypass. This is one of the earliest weight loss surgery that has been reported in English literature somewhere in the 1950s. This is a malabsorptive type of surgery. However, due to complications now, this is obsolete. However, it's better to understand the anatomy. So in rare instances, if you see this kind of an anatomy, you can correlate with the surgical history. The complications associated with jejunoileal bypass, given that there is a long segment of the small bowel that is bypassed has led to hepatobiliary disease, electrolyte imbalances, including renal stones, as well as bypass enteritis. Here is an illustration of a jejunal-ileal bypass where an end-to-side anastomosis is created of the proximal 50 to 100 centimeter of the jejunum, approximately 10 to 20 centimeter upstream of the terminal ileum. And that means that a long portion of the small bowel is excluded. This is the jejunal-ileostomy. If you look at a fluoroscopic imaging, you will notice that the jejunum is very short, as looks like a short bowel with the feathery appearance and terminates directly into a more distal ileum. And majority of the bowel loops are not opacified because they have been bypassed. So in conclusion, knowledge of the common bariatric procedure helps you to understand the normal radiologic anatomy and also helps to identify common postoperative complications on imaging. It is also important to know that fluoroscopic study is the primary imaging modality in evaluating bariatric surgery. Scout and delayed images are extremely useful. Here are some of the selected references for you to have a detailed understanding and to review these at your pace to understand the anatomy and postoperative complications. Thank you for your attention.